My presentation is on behavior modification. This topic is slightly different from what you have been hearing since morning on diets, ketogenic diets, intermittent fasting, and blood donation, and all these topics. But I believe this is a very, very important topic. In the morning session, Shilpa Joshi ma'am mentioned that in India, the average A1C value is 9%, which is 2% above the recommended control. At least 45% to 50% of patients with type 2 diabetes fail to achieve adequate glycemic control. One of the major contributing factors, according to me, is poor adherence or non-compliance to treatment. And this is a fact which is very well documented also. Poor medication adherence is linked to factors like unavailability of integrated care, and sometimes patients' education level is not up to the mark, the income level is not there. Sometimes patients' beliefs about the medication is wrong. Sometimes there is treatment complexity. Sometimes there are fear of medications, like they might fear hypoglycemia. Now, solutions to these problems require behavioral interventions. And I am going to try and cover these interventions in this talk to my best capability, though behavioral interventions would require a full training of the healthcare professional. Now, effective diabetes management requires both clinical care and good self-management by the person with diabetes to achieve optimal health outcomes. And for this, both diabetes-specific behaviors and lifestyle behaviors need to be addressed. That is because managing diabetes is a challenging thing, because it is a condition which is lifelong. Now, this particular characteristic is very, very important because it's not like a viral disease or a diarrhea which will come and go. It is a lifelong thing. It is unpredictable. I'll just give an example. Like, mostly people with diabetes would think that I'll just go for an exercise and my blood sugar would drop. But when they check their sugars, it is actually higher than when they started the exercise. It has scientific reasons behind it, but according to the brain of the person, it becomes unpredictable. It is variable over lifespan. Whatever is working for the person right now may not work after 5 years. That brings a feeling of sometimes failure in the person, that I'm doing everything correct, but still my sugars are getting uncontrolled. It is very psychologically demanding, because once a person gets diagnosed with diabetes, from the family to the friends, somehow starts blaming the person sometimes. Even the person himself starts blaming that I might have done something wrong to be diagnosed with diabetes. It requires knowledge. Diabetes management definitely requires knowledge. Hypoglycemia, hyperglycemia, foot care, sugar monitoring, all of this requires knowledge. It requires confidence. Coping up strategies require confidence. It requires motivation, because continuously you have to keep telling yourself that I have to do the right things. It requires motivation, and it requires behavior change skills. Here is a harsh reality of India. Now, this study, the ICMR in-depth study, this study estimated the levels of glycemic control among subjects with self-reported diabetes in urban and rural regions of India. Now, study was conducted in a representative population of 3 states of India: Tamil Nadu, Maharashtra, and Jharkhand, and 1 union territory, Chandigarh. Now, as you see, the glycemic control, the A1C, which is less than 7%, was actually only in 31% of patients. And 213 million people were covered. Now, what is the reason? The reason could be non-compliance. And detecting non-compliance is very, very important for adequate treatment of the patient. Because if we do not detect non-compliance and we keep increasing the medication dose, whether it is insulin or whether it is a drug, then we don't reach the right outcomes. When we talk about non-compliance, it could be primary non-compliance, it could be secondary non-compliance. Now, what are these? Now, primary non-compliance is when patient fails to have the medication dispensed. And secondary is when patients don't have the medication as instructed, which we most often than not see, that patient sometimes is having insulin after the meal or sulfonylurea after the meal. According to their own convenience, they start changing the medication timing. The other categories relate to the intention of the patient. sometimes the patient completely rejects the prescription given by the doctor. Like, I will not take insulin, or I will not take an SGLT2 inhibitor, or I will not take a gliptin because of the cost. Now, sometimes there is unintentional compliance. It could be social, demographics, psychological, or sometimes clinical variables. Now, clinical variables would be, say, suppose you have told a patient to take care of an ulcer in a particular manner, but because of retinopathy, or because maybe the person is so overweight that he cannot bend down and check it, or because of eye issues, the patient cannot take care of that ulcer. So what are the behaviors for non-compliance? This is a survey which was done, and some behaviors that came forward was I forgot to take my medication, I ran out of them, I was away from home, I was trying to save money, I had certain side effects, I was too busy, prescription wasn't working, didn't think about prescription was needed, didn't like taking it. So when we talk about behavior, we're not talking about behavior as in the mannerisms. What is health behavior? Health behavior can be defined as any pattern, any habit, which can affect your health, whether it is negative, whether it is positive, and believe me, it has a great capacity to affect it. What are the behaviors which are relevant to diabetes? Behaviors relevant to diabetes are self-monitoring, very important, eating healthy, regular physical activity, medications, healthcare professional visits, and some eye and foot examinations. Now, the other words that we have to be familiar with are compliance and adherence. Many people think it is the same thing, wherein it is not. Compliance is a passive behavior in which patient is just following the list of instructions from the doctor. So patient has a list of instructions that you have to do this, and patient keeps following. For example, patient ko 10 units of Lantus lagane hai raat mein, and patient keeps putting 10 units of Lantus irrespective whatever is the fasting. Wherein adherence is a more proactive, positive behavior, which results in a lifestyle change by the patient who follows a daily agreed upon regimen. So in adherence, the patient is actually a partner, has agreed to the treatment, and is actively participating. For that patient, maybe if the fasting is high, he will start increasing the bedtime dose of the long-acting insulin, or decrease if he is having a hypoglycemia, right? Now, in mid-1990, the UK Department of Health and Royal Pharmaceutical Society of Great Britain started a collaborative project that aimed to understand why patients don't take their medications. The resulting report, From Compliance to Concordance, developed the concept of concordance. Now, what is concordance? Concordance is a concept in which the patient is viewed as equal to a healthcare provider, which means the patient has the right to make decisions, informed decisions about the treatment. And the doctor-partner relationship becomes a partnership, which is now very, very important, because these days many patients are very, very informed. Different treatment options available should be explained to the patient, and not only options, but maybe what the patient would see as a side effect, right? So here is a case study. It's a young diabetic, age 42, senior bank manager. This is a case which you will very normally see. A1C 9.3, obese. Now, this patient has many options to follow. You know, you can give him metformin, SGLT2, GLP-1 analogs. All of this can be given, but he's reluctant for a lifestyle change. He stopped medications 9 months ago because there were no symptoms. He's taking an alternative therapy. So what is there? What is missing? For good clinical outcomes in diabetes, we say medical adherence. We talk about medical nutrition therapy. We talk about lifestyle management. But we have to bring in what to make all this happen. We have to bring behavior modification. But behavior modification isn't easy. Behavior changing isn't easy. And especially in diabetes, because living with diabetes is uncomfortable, distressing, relentless. Sometimes people are in guilt. They require confidence. For sometimes doctors, it is difficult to understand why simply taking care of one's health is so difficult. But for a person with diabetes, sometimes it is very difficult to incorporate all the healthcare behaviors we're talking about. Go for an exercise, follow a healthy diet, check your sugars. It becomes very, very difficult. Adjustment to diabetes. The minute the patient is diagnosed or even any sudden change in the life brings in denial. Why me? Lab report is wrong. Doctor is lying. It cannot happen. I didn't have a family history. And especially in type 1 diabetes, the parents immediately go into denial. Anger. Why the hell it should be me only? Guilt. Many patients you must have seen come to you saying that, okay, let me not start the insulin, let me not start the medication, let me go for the gym, maybe the diabetes will go away. I just may have had a bag full of mangoes, maybe I will stop eating sweets. So all this bargaining starts happening. When the patient actually realizes, sometimes patients may even go into depression. Now, denial is not a negative emotion. Neither is depression here. Sometimes denial is actually good. But if the denial continues, then it is wrong. So after all this, sometimes acceptance comes in. But it is not necessary. If the patient has gone into acceptance, it is over. The patient can revert back to any stage. Minute there is any change, maybe the sugar goes up, or you introduce insulin, or there is any complication, they can just revert back to any stage. So for a diabetes educator, it's very important to identify and then counsel the patient. Now, what are the attributes of behavioral objectives? The first is that it has to be very agreeable. What do I mean by agreeable? Say, suppose the patient has come for hypoglycemia education. Now, you are talking about prevention and symptoms, wherein the patient wants to understand that if I go into hypoglycemia, should I call you first? Can I inject my insulin at that time? Can I have a sweet and then inject insulin? Or can I have my favorite candy at that time? So it has to be agreeable. So you should be talking what the patient wants to understand. It should be very realistic. It should take the patient to be, to successful goals. It should be very realistic for the patient. Means it should not be, okay, lose 15, 20 kgs. It should be make it, okay, this month lose 3 kgs. Or maybe just add 2 plates of salad. It is to be very realistic for the patient. It should be specific. For example, walk 30 minutes once a day, measurable, and very person-centric. For example, if you're telling a patient to check sugars with a glucometer, make him sit down, check in front of you. So very person-centric, according to the person requirement, right? So it is often assumed that low motivation is a result of lack of knowledge. The knowledge is important, but it is not sufficient. Motivation means degree of wanting or desire or intending to carry out actions. Now, health-related motivation is supported by beliefs, attitude. It is sometimes also assumed that people can be motivated by warnings of future, like we try to warn people that, okay, you follow this diet or insulin will be started for you, or you will suffer from complications. Now, evidence is mixed about effectiveness of fear appeals. Fear could be counterproductive, leading to avoidance or denial and worsening of health behaviors. So fear is only effective if a person sometimes has control and has resources. So I would say promote self-confidence, coping strategies, active self-management, and resilience are more effective motivators than fear. A method of counseling called motivational interviewing was developed in 1990. So it's not a new concept. The central idea is that the people need to want, intend, or be ready to change for any change strategy to be effective. Which means sometimes we think that we want to change, like we want to lose weight, but we are not ready to make the change for losing weight, which means we're not ready to exercise, we're not ready to follow the diet, we're not ready to leave the parties of the weekend. So motivational interview actually explores the feeling of the person for the behavior that one wants to change. So OARS is a technique in which we start with open-ended questions, which means we do not ask a question which ends in yes or no. We appreciate, we reflect, and we summarize. Now, I will just talk about what is reflection. Reflection is a strategic way. So, for example, if a person says that, okay, I don't have time for exercising. So you just amplify. Amplify means just amplify by your voice. For example, do you really think you can't take out 15 minutes a day for exercising? So you've amplified it. Double-sided means that you talk about the difference in what their goals is and what their action is. Like you're wanting to lose weight, but you want to drink alcohol on an everyday basis and more than what is recommended. How will it help you? So it is like a double-sided thing. You reframe it. Like Reframing, like a nagging wife could be a caring wife. Insulin injection could be insulin treatment. So reframing. Agree with a twist, which means you can agree to what the person is saying, but add a benefit to it. Now, these are advanced skills. If I start going into each, it will take a lot of time. But this is called motivation enhancement therapy, which we start with empathy. I'm sure as diabetes educators, we all know what is empathy is. We develop discrepancy in goals and actions. We always avoid argument with the patient, and we roll with resistance. And we support self-efficacy, which means we tell that the control is in patient's hands. Now, this is another technique, and especially works when the patient is started on insulin. Talking about what is going in the patient's life, background, maybe he'll tell you that he's not wanting to start insulin. How does it affect? Why is he afraid of insulin? What is it that it bothers him the most about it? How do you think he can handle it? And then empathize. So you don't give the solutions. You talk about how the patient will find solutions to the problem. So it's a very, very famous technique, BATE. Second famous technique is frames. Specifically address the concern, which is feedback. Put the responsibility on the patient, that he who has to find solutions to his issues. Discuss goals, advice, maybe give some alternatives, empathize, and put the control in the patient's hands. So diabetes educator role is always not to give answers, but make the person understand the issue and resolve with the patient and find the solution with the patient. But never say, okay, do this. No, let him find the way how to do it. These are 5 A's and 5 R's. 5 A's: ask the issue, advise, assess, assist, arrange. 5 R's: relevant questions, risk involved with the pros and the cons. What are the rewards if he does the right things? What are the roadblocks that he will face? And try and repeat what you have counseled. Now, this is cognitive therapy. So when a person is diagnosed with diabetes, and you think a lot of things are running in the person's mind, like, why do I deserve this? Can I do this? Am I a failure? So you challenge the person's thought, that is this thought process helping? Are you actually doomed if you're a diabetic? Is it true? And then put a positive thought process in the person's mind by discussion. So all this requires actually a very good training. Could take 2-3 days for healthcare professionals to be trained in this. Now, this is again a very, very famous model, the trans-theoretical model. It has 4 components: stages, self-efficacy, decisional balance, and process of change. Now, if you see, this is the stages of behavioral change, which talks about a person is in pre-contemplation, contemplation, preparation, action, and maintenance. Pre-contemplation stage is when the patient is completely unaware of the problem that a person is having. So it has no knowledge. Then becomes aware, but has no desire of changing. Then prepares, then learns and tries to understand that, okay, I have to make a change. Then practices the change and then actually maintains for more than 6 months. Self-efficacy is a second component of model. This talks about how confident the person is on a scale of 1 to 10. So you can actually ask the person. This actually tells us how well the person can go ahead and maintain the change. Third component is, yeah.
Sorry, we have a last minute left.
Yeah, I'll just finish. I'm just about to finish. Third component of model is decisional balance, pros and cons. So how will he benefit and how will he not benefit? Process of change is the last component of model. It tells you what the educator can do, like consciousness raising in the pre-contemplation stage. You can give information. Dramatic relief, you can make him introduce like a support group. Supportive relationship is your self-re-evaluation, environmental re-evaluation. How can he help himself? How can the environment help? Self-liberation, you can actually make him sign a contract like, I will not smoke or I will go for a walk every day. Stimulus control, always make sure that the person does not go back to the old habits. What is the stimulus? Like, does he go to a particular friend's place where he starts drinking or eating wrong? Counter conditioning is try to push him towards the stimuluses which get him back to the correct behavior. Reinforcing definitely is always required in the maintenance stage. Health belief model is based on the fact that patient has beliefs about certain key factors and adopts healthy behaviors on his beliefs, like how susceptible he is to the complications. If he feels he's never have complications, he will not take diabetes seriously. If he feels that my diabetes is not serious, he will not take medications. If he feels that his treatment will give him side effects, he will not take treatment. If he, before even starting a treatment or your diet plan or physical activity, thinks there are barriers to it, he will not start taking treatment. So you have to understand that what is the perception of the patient here, and then maybe help him like that. So I think we can do it. Yes, we can do it. We can change behavior. And there has been a study review which says that, okay, behavioral change therapy can help people. Body weight was reduced, A1C reduction was seen. So I think we can have a pat on the back. This is the team that works on behavior modification, that works towards compliance. And thank you. And I think COVID-19 has actually been a teacher for behavior modification. We have all modified our behaviors. We have started wearing masks, washing hands, not shaking hands. Thank you.